the
You're on. Cruise.
Hi, Anita, how are you?
Good, how are you?
I'm good, I'm good. Can you see my screen?
Yes.
Okay. Perfect. Can you hear me well?
Yep.
Okay.
Yes to both. Oh, I think it just went to your desktop there.
Yeah.
Okay.
Just trying to. Okay.
Not sure where it looks. I know Don Kleindorfer was presenting Grand Rounds today. I don't know if that's where the folks are, but maybe give it another minute, and then other than that, you can start
That's
whenever you want.
Is it the presentation back?
Yeah, your slides are back up now.
Okay, perfect. Thank you.
You guys know if I click present review, will you see the notes on my PowerPoint if I share screen or screen share, sorry?
You shouldn't, but we can try it out when it's your turn. And
Okay.
you know,
If not, that's fine. I was just wondering if it actually works because
Yeah, it should work.
yeah, sometimes it's when it's like a computer and a projected screen, but on this
Mhm.
on the Zoom, it sometimes will show you the whole thing. So I can let you
Okay.
know. Ron, whenever you want to get started, go ahead.
Okay. Perfect. Hi, everyone. Ron Gavidia. Today, we're going to present the Journal Club with Dr. With First Jamal. And we're going to start with this topic about the p-values. So today we're kind of helping with this topic. Originally, this was assigned to Dr. Dunietz, who actually provided the slides for this presentation. So we're going to review this very intriguing topic about the p-values, which is it's kind of really one of the most confusing topics in statistics, because what it means to have a p-value less than 0.05, right? So to begin with, it is important to recognize that whenever we conduct research, we end up with databases, and obviously we apply some statistical testing to that to kind of prove or to kind of test the hypothesis that we want to test. And for that, we obtain what is called the test statistics. And then the test statistic is basically just an estimation of differences between, let's say, populations, or in certain aspects, or even hypotheses. But that is typically associated with the p-value. And the p-value it's a probability, but what exactly is? So for some people may say that the p-value is the probability that chance is responsible for the results in less than 5%, or the probability that the results are true results in more than 95%. So for the fellows, which of these two options do you think is the right one?
I'd say the chance the results is less than 5%, so the first one.
Okay. Anyone else? Okay. So out of these two options, actually, none of them is true, and that kind of speaks for the the complex concept of the p-value. So just advancing. Okay, so let's look at this example. So here we are comparing. So we have this 2x2 table, and we are comparing the OSA diagnosis based on the PSG versus the home sleep apnea test. And the hypothesis that we're trying to test here is that there is a difference between the diagnosis of the PSG versus the home sleep apnea test. That's the alternative hypothesis. But we also have a null hypothesis. So that null hypothesis is telling us that there is actually no difference between the two, and it is similar. However, here in this 2x2 table, we see that people with OSA was identified 35% based on the PSG, and almost 49% based on the home sleep apnea test. So when we plot the data, we see that we have 35.2 versus 48.8. And this comparison provides this p-value of 0.04. So is this kind of telling us that there is a 4% chance of this being explained, or if there is a possible probability that this difference is explained by 4% based on chance? No, actually the answer is this one. And this is very important. Under the null hypothesis, or assuming that the null hypothesis is actually true, there is a 4% probability to observe a difference between home sleep apnea test and the PSG that is similar or greater than the difference we found. So what does that mean? It means that it's extremely rare, or it will be extremely rare, like 4% or lower, to identify that difference. So that means it is statistically significant. So what happens, for example, if we have, in this same example, if we have 10% or a p-value of 10%, we're going to discuss that later on, but it is correct to say, based on this information, that the OSA diagnosis was higher in the home sleep apnea test versus the PSG. Again, number one, we have a p-value of less than 0.05, and we also have this difference of 13.6% between the two groups. So the OSA diagnosis was higher in the home sleep apnea apnea test versus the PSG. However, it is incorrect to say that the home sleep apnea test is superior to the PSG because we already know that that's not the case, right? So there is evidence suggesting that, or there is evidence that PSG is superior, is the gold standard. So the p-value, and this is important, the p-value, even if it is a statistically significant, it is a probability. So this doesn't mean that there is no certainty or it doesn't mean that this is true, okay? And then what happens, for example, if we have a p-value of 10 or 0.10? So with the not rejecting null hypothesis, as opposed to the previous one, with the previous one, we reject the null hypothesis that said that there was no difference between the two because there was a difference. But if we get a p-value of 0.1, we do not reject a null hypothesis based on the 5% threshold that we already have. And we conclude that the PSG and the home sleep apnea test have the same OSA diagnosis. The question is, if we have a p-value of 0.10, can we conclude that the PSG and the home sleep apnea test have a different or the same diagnosis rate? Any other fellows? So with the 0.05, we know that there was a difference, but with 0.5, with 0.10, can we say that PSGs and home sleep apnea tests have the same diagnosis rate?
No.
No.
Comments? No, we cannot say that because we did find a difference. Although the difference is definitely not statistically significant, but just because we didn't reach that statistical significant level, it doesn't mean that there is no difference. So we still saw 13.6%, right? So, and this is something very important that we need to take into account when we will review the difference between statistical versus clinical significance, which might be totally different. So because of certain concerns about the p-values misuse, based on the previous example, the American Statistical Association actually released this statement in 2016 in relation to the p-values. So they basically said the scientific community not to use the p-values as a standalone and to use other factors. So they say the scientific conclusions should not be based only on whether a p-value passes in a specific threshold. Scientists must consider a broader range of information to reach the scientific conclusions, such as how the study was designed, what methods were used to minimize chance, bias, and confounding, and also what previous studies on the topic have shown in the past. So that means basically plausibility for the findings. So, p-values, so for the interpretation of the p-values, we assume that the study was well designed. If we don't have a good design, definitely the p-values will not be accurate. So the p-values cannot be understood definitely with the lack of context. So we need to have information about all those aspects to actually to basically contribute to scientific decision making. And then let's talk a little bit about the history of the p-value. So why 0.05? So this concept was initially introduced by Carl Pearson in the year 1900, and this was in association with the chi-square test. However, it was actually Ron Fisher in 1926 who introduced this concept of the p-value or the statistical significance at less than 0.05. And that was in different contexts or different situations beyond the chi-square test. So, and he thought that perhaps 1/20, which means 0.05, was a reasonable threshold to use, but there's actually no mathematical reasoning for that. It's just an arbitrary dichotomy to say what can be statistical significant and what cannot be statistical significant. And because of those things is that we need to bring other factors that to take into account for the statistical significance. Okay, for example, and now let's talk about the statistical significance versus clinical significance. So, for example, here in this study, they found that country music was statistically significantly associated with daytime sleepiness. So the question here is there a possibility about this? Perhaps not. Okay, so let's look at this example and in relation to the statistical significance versus clinical significance. So here we have a series of studies, 6 studies that explore differences between age differences between obese and non-obese groups. As you can see in the non-obese group, everyone has the same age, and obese, we have the same age as well. And the difference between the two is kind of 0.03 years. And what is actually different from the groups is that is the sample size. As you can see, as we go down, the sample size is getting larger and larger. And as that is happening, we see that the standard error and the p-values are getting smaller, smaller, and smaller. Just to remind you, the standard error is basically a measure of how precise the estimated sample mean is from the population mean. So it is very important. So, and as you can see, as the sample size goes down or increases in number, we have a more narrow and narrow standard error, which means this more precise. And we also have the p-values getting smaller, smaller until we finally reach a statistical significance. So, but then again, even though it is the same 0.3 years, there is a statistical significance, but is there any clinical significance? Perhaps not, right? Now let's look at this example here. So we have 2 studies. So the first one, again, comparing the age between the 2 groups, obese and non-obese people. Here the sample sizes were 20 and 20, and then here was 7,000. So the difference in this small group was almost 2 years, and it was not statistically significant. And in this one was 0.3 years, and it was statistically significant. So this is telling us that the p-values provide information about the magnitude of the effect size. And in this case is, let's say, almost 2 years for the first one and 0.3 for the second one, and also the sample size. So again, in this example, the large sample size of the population 2 is actually the one driving the conclusion that age is statistically significant, but not necessarily clinically significant. So regardless of the p-values, there's a clinical meaningful difference in mean age among population 1, but not necessarily in population 2. So that's why it is very important not to rely specifically in p-values, because it could be misleading. For that reason, the recommendation now is, besides the p-values, we should be using confidence intervals, and the confidence intervals provide more context because that they provide a range of values with a probability of 95% that the population parameter will be included within that range. So that's why it's very important to provide that piece of information. Okay, so let's look at this example here. So in this example, we have 4 studies where they were exploring 4 different exposures, A, B, C, and D, and the outcome was the odds ratio of live birth. So as we can see here, comparing the effect of the 4 exposures on the odds of the live birth, assuming a well-designed study with minimal bias and confounding. Question number 1, how will you interpret the relationship between the exposure and live birth? And number 2, which exposure is more important to influence the live birth? Any opinion? Fellows, any opinion?
Exposure A.
Sorry, what was that?
Are you asking which exposure?
Yeah. So the exposure, no, the question is, how will you interpret the relationship between the exposures and live birth? So what's the meaning of this odds ratio with this p-value in the across the board?
So I guess sorry. I guess in like reference to each other, the best way I can like state this, or at least I understand, to answer question number one, is that exposure A has like the strongest association between the relationship between exposure and live birth because its confidence interval, or the range of the confidence interval is like this is yeah, it doesn't, not only does it not cross one, but it's also like the range is small and the p-value shows that statistically it is very significant between the two. And then to answer question two, the one that's more important also seems like it's exposure A, just because the confidence interval does not cross one, but it's also its range is the lowest and its p-value is technically the lowest too.
Exactly. Great job, Yema. Yeah, so A and B are the ones that, the factors that were statistically significant because for increased odds of live birth. And C and D were not associated with the live birth because they have a p-value less than 0.05. However, you were pointing out to something very important here, and is basically the confidence intervals. So the confidence interval, the more narrow the confidence interval, the more precise the information that you're getting from the data. So even though, as you can see, the odds ratios were the same across the 4 studies, the confidence intervals and the p-values were different. So this one, as you mentioned, is the strongest compared to B, and then B was different from C because C was not statistically significant. Okay, good. And then how does the addition of the confidence interval expand the understanding of the relationship? You already said that, right? So by including the information provided by the confidence interval, we have a better sense of the precision because it is more narrow, and that's basically is telling us that the measures or the measurements will be perhaps closer one another. So let's just review this example here just to check again the concepts of accuracy and precision. So remember that accuracy is how close a given set of measurements are to their true value. So that means on target. And then precision is how close the measurements are to each other. So for example, if you have high precision and you have high accuracy, everything is a target, and also the observations of the measures are very close together. And the opposite, when we have low precision and we have low accuracy, everything is just spread out and totally out of target. So yeah. And then here, when we compare exposure B and C, we see that the difference in the magnitude of the confidence intervals between the two exposures is very minimal. 1.01 to 178, and you see 0.99 and 181. They're pretty similar, but as you mentioned, Emma, this one is crossing 1, so that's why it is basically not statistically significant as expressed by the p-value, but also this is telling us that it's not statistically significant, so that was a good job. And then when we compare C and D, we see that both exposures are not statistically significant. However, the precision in C is greater than the precision in D. Why? Because the confidence interval is wider in exposure D, and the p-value is higher. Okay, so again, confidence intervals show the information about the size, the effect size, and also about the precision of the effect. And also, it is important to remember that including the p-value in a table does not provide any additional useful information from what is provided in the confidence interval alone. And even now, some reviewers, when you submit papers, they actually tell you to take down the p-values because what they want to see is only the confidence intervals. Okay, well, I think that's everything that I have for you today's guide, and I'll be happy to take any questions if there's any. If not, I will pass to Fears for the journal club.
Dr. Gavidi, I have a quick question.
Sure.
So in terms of the sample B, given how like the confidence intervals like basically almost at 1, like even though it's considered statistically significant, like clinically that may not be like significant if it's like almost equivalent per se. It's like close
Yes.
to one.
Yeah, that is true. That is true. But that's why it is still statistically significant. But as you mentioned, clinically speaking, may not be that meaningful. However, we're talking about Lightbird, right? So perhaps something even minimal may be considered something meaningful at this point. So, but you're right. However, as long as you're not crossing or you're not reaching the one or crossing the one, it should be considered significant. Of course, within taking into account the plausibility and also the how clinically significant that could be depending on the context.
So confidence interval is more of accuracy, and then the p-value shows the precision. Am I understanding that right?
Actually the confidence interval is giving you information about the precision.
I see. So it's, yeah, okay.
Yeah. Okay. So if there are no more questions, first, it's all yours.
All right, cool. Welcome everyone to the journal clip today. Can everyone hear me first of all? Okay, good. Maybe some of you had the chance to look over the article I sent over. And here we go. So the article I chose was called "CPAP May Promote an Endothelial Inflammatory Milieu in Sleep Apnea After Coronary Revascularization." Here are the authors, and the declaration of interest I thought was important. They did receive a grant from the ResMed Foundation as well as ResMed Ltd. Received consulting fees from ApneaMed and some other consulting fees and support from other companies here. But ResMed did give some institutional grants for this study to be conducted. So the reason why I chose this article, I had a few considerations in mind. I think as a fellow, we're just kind of sometimes all we do is like increase the CPAP pressures for patients, or we decrease them, or we play around with the numbers, or when reading the sleep studies, we're just happy to, not always, but you just like the highest pressure sometimes happens to be the best pressure that's most effective in treating the patient's sleep apnea. So I was like, in the back of my head, I'm like, are pressure changes always benign? That's a question I had, a consideration I had that helped me choose this article. And how do we balance improving health outcomes by minimizing respiratory events versus decreasing the adverse outcomes from higher CPAP pressures? So this article will kind of talk about what the dangers of increasing pressures are in a specific patient population. That is those who have CAD and have undergone some sort of coronary revascularization. Some other considerations, prior to this study, there is evidence that persisting cardiovascular risk in patients with OSA after CPAP therapy, despite the elimination of the hypoxia, that there's increased cardiovascular risk in patients with OSA, despite eliminating the intermittent hypoxia and consolidating their sleep. So CPAP therapy doesn't always eliminate the CVD risk. And more conservative CPAP levels, this is kind of a personal goal. CPAP levels that control daytime OSA symptoms should be considered to minimize potential side effects from CPAP, even if they do not eliminate all respiratory events. I think that's important. So when we look at a study, taking into account the patient's history and maybe CVD risk, as well as prior revascularization, we should maybe consider not eliminating all respiratory events. And even if they're having a few, maybe that's okay. So these are kind of the considerations that I had, and it helped me choose this article. So the article itself, the objectives were to investigate whether CPAP, continuous positive airway pressure, typically used to treat sleep apnea, could promote endothelial inflammation in patients who had undergone coronary revascularization. The clinical prevalence, I touched upon this a little bit, but sleep apnea is common in patients with CVD. CPAP is commonly used to manage the condition of OSA. So what are the impacts on the on CPAP's what are the impacts on cardiovascular health, particularly the endothelial function after coronary revascularization in patients who are using CPAP? So the outcomes of this study, the primary outcome was the change in circulating levels of angiopoietin-2, T2, sRAGE, which stands for soluble receptor of advanced glycation end products, E-selectin, as well as vascular endothelial growth factor A. From baseline to a 12-month follow-up in CAD patients who were newly diagnosed with OSA after coronary revascularization. The secondary outcomes of the study were the association of CPAP levels with biomarkers and a composite cardiovascular outcome, right? Meaning repeat revascularization, myocardial infarction, stroke, hospitalization for cardiovascular disease, causes, and or cardiovascular mortality, as well as the association of biomarkers with a composite cardiovascular outcome and all-cause mortality. So I want to kind of talk about the biomarkers that were studied and that were assessed, since I think that's important before we kind of get into the study. So angiopoietin-2 or Ang2, it's involved in endothelial function and vascular remodeling. It's also a marker of endothelial cell dysfunction and inflammation. High levels of angiopoietin-2 are associated with vascular injury as well as endothelial inflammation. We have T2 here as well. I think that's how you say it, TIE-2, a receptor that plays a role in the endothelial cell survival, as well as angiogenesis. We have sRAGE, right? Soluble receptor of advanced glycation end products. That's a marker for lung epithelial inflammatory function. It could also be related to systemic inflammation. It's primarily used as a marker for lung injury, but it can also reflect endothelial dysfunction and systemic inflammatory states. E-selectin is an adhesion molecule related to endothelial inflammation. And then we have vascular endothelial growth factor A, VEGF-A. It's a protein that stimulates angiogenesis and is involved in vascular permeability. And it's a key factor in endothelial cell function, as I said, angiogenesis. Some of the important things to kind of add on here when speaking about the outcomes is that the treatment of patients was randomized to CPAP versus usual care. And moreover, to assess the natural trends in the levels of these biomarkers that I just mentioned after coronary revascularization, the study also measured these markers in patients with CAD after coronary revascularization who were OSA free. So, and that was kind of defined as having an AHI of less than five events per hour. So this is a diagram I took from the article, which kind of shows the relationship between obstructive sleep apnea and increased cardiovascular risk. I kind of like it because it also shows how CPAP may potentially also lead to inflammatory states that might increase cardiovascular risk. But the idea is that obstructive sleep apnea untreated leads to intermittent hypoxia. There's endothelial dysfunction and then increase in your inflammatory biomarkers, specifically here, the angiopoietin-2 that we spoke about. And then CPAP itself, and we'll get into this in more detail later, you know, there's a thought that it could increase the alveolar distension and also increase angiopoietin-2 inflammatory markers that increase cardiovascular risk. And here we have the, I guess I could call it VEGF, vascular endothelial growth factor A. So in general, CPAP therapy reduces OSA-associated hypoxemia with favorable effects on endothelial function and inflammation. But CPAP therapy also appears to alter the pattern of plasma biomarker expression after coronary revascularization in OSA patients. So in a way that favors inflammation rather than angiogenesis. So this just brings me to a point that I want to make. Here we're assuming that angiogenesis is a favorable organic process. I kind of looked into this myself on the side. There's a lot of research on this topic. Briefly, the idea is that angiogenesis is important because it can be a target for combating cardiovascular pathology, which is characterized by either poor vascularization or abnormal vasculature. The idea is that the processes that inhibit or induce the creation of new blood cells and blood vessels in the body may help combat these diseases. Angiogenic cytokine therapy is gaining some traction in this field. It's been widely regarded as an attractive approach for both treating ischemic heart disease as well as enhancing arterioprotective functions of the endothelium. So the effects of angiogenic therapy are still being studied, and it just needs further study. But the idea is here that angiogenesis, we're assuming, is a good thing, and the other inflammatory states are a bad thing. So here's a study. Here's a slide on the study design and the methods. I kind of want to go through this. I guess we could start with what kind of study this was. This was a secondary analysis of a randomized clinical trial. So that means they looked at existing data of actually two studies: randomized intervention with CPAP and CAD, as well as the OSA Ricardosa study. The original studies involved the randomization of patients with obstructive sleep apnea and coronary artery disease that either received CPAP therapy or usual care after coronary revascularization. The patient population were patients with sleep apnea who had undergone coronary revascularization. So we started off with 1,291 CAD patients who were screened after coronary revascularization. And then the inclusion and exclusion criteria. The inclusion criteria was that the patients had to have newly diagnosed moderate to severe OSA, and they defined that as an AHI of either more than 15 or more events per hour of sleep after a PCI or a coronary artery bypass grafting for coronary artery disease. The exclusion criteria was that patients with mild OSA, so AHI between 5 to 14.9 events per hour, were excluded. Those who had treated OSA were excluded. Those who had central apneas on their HSATs were excluded, and patients with excessive daytime sleepiness were excluded. And that's for ethical reasons, right? Well, they cannot be patients who had OSA with EDS, Epworth Sleepiness Scale score of more equal to or more than 10, could not be denied CPAP therapy owing to the risk of an MVA. So 189 patients with OSA and coronary artery disease were randomized to CPAP therapy. So that was around 91 patients here at the end, or usual care 98. An additional group of OSA-free CAD patients right here were analyzed for trends in biomarker levels. So that was kind of the control group to analyze the trends of biomarker levels being for patients that were OSA free. And the changes in endothelial biomarkers, the ones we mentioned, right? Angiopoietin 2, T2, E-selectin, VEGF-A, and lung epithelial biomarkers such as SRAGE were measured from baseline to 12 and at the 12-month follow-up, and were compared across groups with cardiovascular morbidity and mortality being assessed. So I might talk about how they did that real quick in terms of the methods they used. So the blood samples were collected at a fasting state between 7 a.m. and 8 a.m. and they were collected at 2 time points, one being baseline after the initial sleep study, and one at the 12-month follow-up. The interventions being used in this study were CPAP therapy, and that was administered to patients with sleep apnea after they underwent coronary revascularization. The endpoints The endpoints of the study was to assess the impact of CPAP on endothelial inflammation, which was the level of the biomarkers at the 12-month follow-up period. In terms of how they assess the sorry here. Okay, so the CPAP therapy protocol, how was CPAP administered? The CPAP pressure settings were individualized for each patient, but the median CPAP pressure that was used was around 7 centimeters of H2O. CPAP adherence, the CPAP therapy was monitored, but the median CPAP usage was 3.5 hours per night, which wasn't too much. The residual AHI in the CPAP group was 4.4 events per hour. The duration of the CPAP therapy, it was administered for 12 months, with, as I said, the biomarkers being assessed at both baseline and the 12-month follow-up to evaluate changes in endothelial function and inflammatory markers. And these are the results. And before I speak about the different biomarkers and which ones were elevated or decreased, I would like to point out that the only difference between the patients that received usual care and the ones that received the CPAP was that hypertension and diabetes were actually higher in the patients who were needing CPAP care. I have the p-values here. Dr. Gavidia just gave a lecture on that, but they were significant in this case. So what did the trends in the biomarker levels at 12 months show? And I can go through this. I think it is important to talk about the different patient groups. So we'll start off with the OSA-free patients. In the OSA-free CAD patients, biomarkers angiopoietin-2 declined while the VEGF-A remained elevated. E-selectin and T2 declined as well, and S-RAGE remained unchanged at 12 months. Patients with OSA and CAD. So angiopoietin-2 levels declined in the usual care group, but remained unchanged in the CPAP group, and the p-value for that was 0.018. After adjustment, the difference between CPAP and usual care remained significant with a p-value of 0.039. And as we remember from a few slides ago, angiopoietin-2 is directly related to endothelial cell dysfunction. VEGF-A levels decreased in the CPAP group, but remained elevated in the usual care group. And then VEGF-A was the marker that was associated with angiogenesis. S-RAGE, T2, and E-selectin declined more in the usual care group, but differences between groups were not significant. Effect on CPAP on biomarkers. So angiopoietin-2 levels were significantly higher in patients with higher CPAP pressures, but no significant relationship was observed with CPAP adherence. No significant correlations were found between CPAP levels or adherence either, and the biomarkers T2, E-selectin, VEGF-A, and S-RAGE as well. Association of biomarkers with cardiovascular outcomes. So angiopoietin-2, higher levels of angiopoietin-2 from baseline to 12 months were significantly associated with greater mortality in patients with OSA after coronary revascularization, even after adjusting for potential co-founders. Other biomarkers were not significantly associated with mortality. And then finally, the impact of CPAP on cardiovascular morbidity. So CPAP pressures more than 7 centimeters of water were associated with a higher risk of the composite cardiovascular outcome compared to CPAP, either at 7 or less than 7 centimeters of water. And the hazard ratio for that was 2.81. Hazard ratio, it's almost equivalent to the relative risk, but uses information collected at different times instead. And here the number is indicating a higher hazard of death from the treatment. And here is a linear regression of what I kind of explained before, where the median CPAP pressures, the higher they go, there seems to be a increase in the angiopoietin-2 levels with a significant p-value. And we also have a
Feroz, I missed and all that. Is it adjusted for how bad their sleep apnea was? Because obviously if you have worse sleep apnea, you might expect higher CPAP.
yeah, the study did say it was adjusted.
I don't know if they could have adjusted it for that graph.
I'm not sure. That's a good question. But apparently there was an adjustment made for patients with OSA and CAD, where they saw that the angiopoietin levels had declined in the usual care group, but remained unchanged in the CPAP group. Apparently the p-value before the adjustment was 0.018, and then after adjustment, it was slightly higher at 0.039. And here's the Cox regression showing how CPAP pressures higher than 7 centimeters of water have a higher risk of adverse cardiovascular outcomes compared to those that were either at 7 centimeters of water or less. And just brings me back to one of the slides I had already showed you, kind of the idea that angiogenesis is a favorable process in patients with cardiovascular disease, and how inflammation might be brought about by higher CPAP pressures. I think we're moved here, or sorry, I'm trying to figure out what slide I'm on. I can't see my notes. Yeah, so the elimination of intermittent hypoxia reduces levels of proangiogenic factor VEGF-A, and then the reduction in VEGF-A in the setting of persistent elevation in angiopoietin-2 was observed after CPAP therapy. And this is what the hypothesis is. This is what increases the risk of recurrent events after coronary revascularization. The increased lung volumes during CPAP therapy might also promote persistent increase in circulating levels of a pro-inflammatory of angiopoietin-2, and then greater levels of angiopoietin-2 and SRH after 12 months of CPAP therapy were associated with significantly greater mortality and increased incidence of cardiovascular events in patients with obstructive sleep apnea. So in terms of conclusions, the major finding of this study was that randomly allocated CPAP therapy changes plasma biomarker expression after coronary revascularization in patients with OSA in a direction that favors inflammatory over angiogenic processes. Compared with usual care, patients with OSA randomized to CPAP therapy for 12 months have persistently elevated circulating levels of angiopoietin-2 and a decline in levels of VEGF-A, which is a proangiogenic factor that is elevated after coronary revascularization. These findings raise the possibility that despite reducing nocturnal hypoxia burden and sleep fragmentation, CPAP, in particular greater CPAP levels may continue rather than improve inflammatory processes in OSA. And some other concerns that came about while I read the study was that CPAP increases lung volume in a dose-dependent fashion. So with 10 centimeters of water pressure, it increases the residual capacity of the lung by more than 1 liter. By increasing lung volumes and distending the alveoli, CPAP may contribute to lung endothelial and epithelial inflammation in a manner analogous to that seen with volu trauma and ventilator-induced lung injury. There's also a concern that the potential effect of CPAP on angiopoietin-2 may actually have been underestimated in the study, since a lot of the patients were on statins and statins are known to kind of stabilize the endothelial cell surface and restore endothelial complement protection, which reduces the release of angiopoietin 2. And this kind of made me think about using statins maybe in patients that have a history of CAD with coronary revascularization, since maybe using it in conjunction with CPAP therapy may actually modulate the effects of CPAP on the biomarkers of inflammation and endothelial function and attenuate any negative effects of CPAP on vascular health. So that was a thought that it was intriguing that maybe we'll get to a point where we'll be prescribing statins for patients who have this history, if they're needing higher pressures to effectively treat their obstructive sleep apnea. So there were a few limitations of this study. I already mentioned like one, the CPAP adherence. It was quite low, right? So 3.5 hours per night. And low adherence to CPAP therapy may limit the ability to detect meaningful changes in biomarkers. And then the variation in CPAP pressure settings also existed. Although the median was 7, it wasn't really standardized across participants. The sample size was also quite small, right? We had 91 patients on CPAP and 98 patients receiving usual care. So it might have been insufficient to detect smaller but more clinically relevant differences in the biomarkers. And it's a secondary analysis, so we're kind of relying on existing data, and there might have been limitations in the design of the original study that we're maybe not aware of. And then the findings I thought were not applicable to all patients, right? So we kind of excluded those who had milder OSA, other comorbidities. Those patients with CAD that didn't undergo coronary revascularization weren't studied. So those are some of the limitations. I did write a little more here. And the kind of the science behind the biomarkers and how they actually may harm versus benefit patients with coronary artery disease is also to be studied a little further, because I don't think we're still able to understand the complexity of endothelial inflammation. And this is just based off of prior research. Okay. And I think that's it for me. Any questions?
Farouz, a couple things with this study, I think that kind of make it hard to really make you could say a judgment call on the study. First, it's kind of a small sample size. I don't think it's enough patients, and a lot of these patients that have coronary artery disease that get revascularization, it's usually their first event, and they're put on a lot of goal-directed medical therapy per se. And then there's parts of it that you could almost say it's dose dependent, and the people that have OSA tend to possibly have more high blood pressure and put on higher medications of those. So a big factor per se that may alter a lot of these, you mentioned it, is medications per se. Like a good example is the beta blocker that they accounted for based on cardiology. Their studies, like the ones that was on the goal-directed medical therapy, was like the metoprolol succinate, carvedilol, and like soprolol, but like the two most common are toprolol and carvedilol. One of them in their studies show actually makes insulin sensitivity worse. The other one makes it maybe a little bit better. But like effectiveness in treating coronary artery disease on that aspect was actually dose dependent. Not only did the patient have to be like basically at max dose of those medications, their heart rate had to be between 55 to 60. Now, how many of those patients actually leave with max dose from the hospital and not put on like one of the lowest dose possible? Not most people get put on all the medications on lower dosages. And then it's kind of a coin toss on which one they pick too. So the question is did these patients have higher like risk of diabetes based on that? That's just one medication. This even includes statins too. Statins usually have a higher chance a little bit for diabetes. Plaque stabilization, I know is a factor. And I know a lot of the studies use 70 as a marker to achieve, in which like I know for hemorrhagic stroke below 70 is a little bit higher. So the question is there a higher chance with endothelial damage because they achieve like the goal of below 70 per se, while some patients don't?
No, I
And
agree
then-
with you. I think the idea was to to have this the separate group, the OSA free patients who just received who did not have OSA at all, that just received the usual CAD care that the patients with OSA also received. I think the sample size is small, but at least their biomarkers appear to be in favor of inflammation rather than angiogenesis. And I think that's where the that's what they were. This article, that's what the article was trying to stress from my point of view.
And then
I don't know if it's gonna change the way I practice. I'm not sure, but it's something that I'm like keeping in the back of my head when I'm just like increasing patients' pressures, especially if they do have a history of like coronary revascularization after CAD.
And then on a separate note, they did do a meta-analysis on, you could say they didn't measure per se LDL, but measured improving like mortality for patients and they on a 5 years being on consistent stat use. And in terms of how many more days they got out of being consistent stat use for cardiovascular risk, they only got like, it was like 4 days or so. So longevity of statins is something that is hard to gauge per se, because it's measured actual life improvements per se in terms of days. So it's hard to really put a conclusion on short term versus long term.
I have a question.
Bruce,
You
great
know, do
job.
you
There are a
think-
couple of comments in the chat too, one from Punita about what was usual care, and then one from
Yeah.
Jin Hung about the median LVEF of the two groups.
I'm not sure about the LVEF. I saw that comment. I don't think they mentioned a median ejection fraction. Maybe I'm wrong, but I don't remember reading that. In terms of usual care, I think Isaac mentioned a few. So the statins, beta blockers, and then the does anyone remember? I don't know if maybe I have the article up. I could see, but I could get back to you, Dr. Vijayakumar. I'm not sure exactly which specific beta blockers they were using.
Mhm.
Just
But
mentioned
it appeared to be.
it just said N. I don't think they actually like separated between beta blockers,
Beta
like which type.
blockers.
Dated right? It was a different like like you were mentioning carvedilol versus metoprolol, but I'm not sure if they actually made a distinction in the article.
I have a question. Is it the inspiratory pressure that causes the alveolar damage or the expiratory? Because they've used the CPAP. How about if we were to use a BiPAP, you know, when you have the expiratory pressure is on the lower side, less likely to have an alveolar, you know, the distension, constant distension.
I think that's a great question. I think part of it, I think it's a twofold answer. I think the alveolar distension, if they used BPAP, might have been, I'm not sure because they didn't use BPAP, but I think one idea is that the pressures increase lung volumes and distend the alveoli. So whether that might get worse with IPAP, I'm predicting maybe, but I'm not sure whether it would. But it also appeared that besides the lung markers, the inflammatory markers of the endothelium also increased with CPAP pressures higher than 7. Whether that's related to, I'm not sure how. I could see if I maybe wrote it down here, but
I think the normal critical pressure for the opening is about 8 centimeter water at the oropharyngeal level.
Mhm.
So I'm not sure anything pressure higher than that is causing some damage. But how would you apply that to our patients? You know, if they still
I have a hard time hearing you, Dr. Vijay Kumar.
how would you apply this to our patients if they still have obstruction? You know, thinking about the higher pressures that they are needed to improve the obstruction.
I just heard, how would you apply this to our patients?
Yeah.
Is that
Mhm.
okay?
Who are needing a
Yeah, I
higher
mean
pressure.
that's a good question. And I think I've had a lot of patients in either in clinic or while reading sleep studies where we just increase the pressures because we want to eliminate all the respiratory events. Maybe taking this into consideration with patients who have cardiovascular history, especially CAD with coronary revascularization, we could maybe be a little more cognizant of the fact that we might be doing some damage. I'm not going to say more damage, but some damage, and then kind of balancing the idea that yes, treating the hypoxemia is going to also help, but increasing the CPAP might also get to a point where we're going to be inducing inflammation rather than angiogenesis. I think Dr. Garwood he inspired me to kind of pick an article like this because we've had a few patients together where, where they had a history of coronary revascularization, and they needed retitrations. But he was also wondering whether that's always the best call to make, whether we should just be happy to increase the pressures without thinking about consequences. I think there's still some room for research to be done. I guess it's more of like a gut feeling, but usually things like this, this is it's more of a newer technology in terms of the effects of CPAP. I don't think that's been like thoroughly researched, like in terms of how it can maybe induce inflammation and prevent angiogenesis.
And I have one more thing, because in this study, they chose patients with excessive daytime sleepiness less than 10. How many of a severe sleep apnea patients have a sleepiness score less than 10? Because they did more than 15 as their AHI score, and right, they excluded all the patients with ESS score more than 10.
Yes. So yeah, they excluded everyone with a very high ESS. Oh, what was I couldn't hear the other part.
No, these patients are asymptomatic with AHI for moderate to severe sleep apnea with the coronary artery disease, right? So when you look at those patients with the higher AHI, most often I've seen they are more symptomatic in one or some other way. And people who have strictly coronary artery disease with the lower AHI, I've seen less than 15, they're more often asymptomatic. And we have excluded maybe, out of 600 patients, how many patients we have excluded, and we don't know what their angiogenesis potentials are, with the.
Yeah, absolutely. I think that's one of the other major limitations of the study.
Good. Very enjoy.
That was great. Thank you, Farouz. I don't see any other hands up. I think it was very provocative in terms of thinking about our standard practices and standard of care, and what are the intended and unintentional consequences of our therapies. So thank you for a great presentation, and thank you,
Yeah,
Rhapsody,
thanks for
as
listening.
well.
Thank you.